Hello, hello, and welcome back to the Dr. Toomer Talk Show. I'm Dr. Catherine Toomer, family medicine and community health physician, and I talk about all things health, wellness, and weight care related. If you are listening for the first time, welcome. If you're coming back, say hello and tell me where you're listening from. And if you like what you hear, follow me on Facebook if that's where you're listening, or subscribe to my YouTube channel and make sure you like and hit the thumbs up for any videos that you watch. I do have over 300 videos on my YouTube channel, so if you're looking for anything related to health, wellness, and weight care, it is there, including menopause, including anything on medications. I am in what they call a GLP OG. I've been using GLP medications for 15 years now. And so these aren't new, and I've been using them. So if you have questions about that, I also have a patient group where I talk about and help coach. So if you're interested in that, I'll give you some more information. And if you want some one-on-one help, you can also do that. You can go to my website and make an appointment to see me, where I do strategy and plan appointments. So lots of things and lots of wonderful things for 2026. And so happy to be here, happy to be back, and much needed break. So um I do my Q&As once a month, usually the first Tuesday of the month. But since I was still on vacation the first Thursday of this month, I am doing it now. So if you have any questions, you can put them into the comments and I'll read them. And I have several questions. I got a lot of questions over the holidays. So I'll be reading those off if I don't get any right now. And so if you just bear with me while I pull some up. I have them in several different places, actually. Probably should have consolidated them, might have made it a little bit easier. So hold on just a moment while I pull them up. Let me see. Hold on. Let me turn down my volume. Where am I? Where am I? Do 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 do. Comments. Okay, let's see what questions we have. Oh, hello, hello. Welcome back. Happy New Year. Happy New Year. It's good to see you guys. So, let's see. Um, okay. So someone wrote, um, what is happening is someone who has been slim all my life and suddenly in 3 months gained 20 kilos. So if anyone understands kilos to pound, that's about 44 pounds. Um, and without changing any of my regimen, or my diet, um, and she's tried everything. She said, I've tried everything, diet, nothing. After 4 years of suffering, I started taking a GLP-1 and all the kilograms were gone. So what exactly do GLP-1s do? And what is metabolic syndrome, insulin resistance, prediabetes, and how does it make it all disappear? Okay, so, oh, well, welcome, Dr. Una. Thank you for coming. So, someone said that they are starting to gain weight, having difficulty losing, no matter what they did. And so she didn't give her age, but it sounds like menopause, because that's usually what happens in menopause. One of the things that happens in menopause are our hormones drop, our estrogen and our progesterone drops. And when it drops, it leaves our cortisol unopposed. So this is kind of what our cortisol does. Cortisol is our fight or flight hormone. It's our stress hormone. It's the hormone that kind of pushes our body into metabolic dysregulation. But our progesterone and our estrogen kind of keeps it in check. When it starts to drop, our estrogen and progesterone, that cortisol suddenly has nothing opposing it and it becomes the driver. And when it becomes the driver, it pushes our body into metabolic dysregulation. And when it pushes our body into metabolic dysregulation, our brain essentially starts taking all the food we eat and tries to make fat out of it instead of fuel for our muscles. When we are in metabolic dysregulation, all functions in our body get thrown off. Our muscles aren't working as efficiently. Our brain doesn't work as efficiently. Our heart suddenly starts having issues with regulation. Our kidneys, our cholesterol, liver starts acting up. So our cholesterol starts having problems and all the rest. So that's what happens during menopause. And so when that happens, even when you're doing the exact same thing, same amount of exercise, same eating the same way, your body starts to take food and turns it into fat. The reason that happens is because that cortisol suddenly starts causing insulin resistance. Insulin resistance is at the low end of the continuum. So that's pre-diabetes. Then you get pre-diabetes, and then you keep going, it becomes diabetes. It's all on the same continuum. Unfortunately, our body doesn't read textbooks, so it doesn't wait until we're diabetic before it starts doing damage. It does all of it all here, and we can start treating it way down here 10, 15 years before diabetes happens and prevent 10 to 15 years of weight gain during that time. And that's what GLP-1s do. They make sure that the message your brain uses to send signals to the rest of the body gets in. When our bodies have insulin resistance, that glucose is not getting into the brain cells to give the brain its signal. And so the brain starts mis-signaling back to the body. When using a GLP-1, that signal now gets into the brain, and the brain says, okay, you've eaten, and now I'm going to start telling the rest of the body what to do properly. And one of the things it does is says, stop making fat. Not only do you stop making fat, but take the fat you've got and start making fuel out of it. So not only does it stop making fat, it reverses the fat that was already made. So that is what GLP-1s do. And in doing that, they also correct for high blood pressure, they correct for inflammation, they correct for cholesterol issues. And you often see this in menopause, polycystic ovary syndrome, chronic stress, people who are on steroids and other medications like antipsychotics and the like. So there's lots of different medications that can cause this disruption, and GLP-1s help with that. Now, and I know the next question is going to be, why is there a way of doing this without the medication? Yes, there is. Now, the reason this happens is when someone's genetic hits a trigger. That trigger could be menopause, it can be pregnancy, it can be stress, it can be, like I said, polycystic ovary syndrome, it can be medications. And so when our genetics hit that trigger, and there are things that can counter that. One of them is muscle, building muscle. When we build muscle, we create a metabolic powerhouse in our body. The problem we run into, depending on where you are in the continuum, trying to build muscle can become very difficult. If you're low down in the continuum or not even on it yet, then building muscle will prevent metabolic disruption from getting worse. If you're somewhere in the middle to the upper part, your muscle work is fighting against that metabolic process, and it makes it very, very difficult. So sometimes it takes a little bit of medication to give the muscles a chance to do their work, and then you can come off the medication. But muscle is the most important metabolic organ in our body, besides the brain, obviously. So muscle is one. The other is stress reduction. Even if you don't feel stress, that doesn't mean you're not under stress. So you just assume your cortisol levels are high and you work to get those cortisol levels down. And those are the two things that can work in place of medication if you catch it in time, or if your genetic trigger has not been, if it's not such a strong trigger. Someone just wrote, thank you for sticking it out long enough to care for and teach so many of us. Appreciate your expertise and training. Thank you so much. And congratulations on your service in medicine. Thank you. Thank you. Yes, it's been this is my 30th year in medicine, so I'm going to be celebrating 30 years all year. So anyway, so that's what GLP-1s do. That's why as women get older, it becomes harder and harder for us to lose weight, and why it's easier for us to gain weight, and usually because there's an underlying metabolic process. Now, yes, muscle can do it. Yes, stress reduction can do it, depending on how far along you are in the process and how much your genetics have been triggered. Some of us just simply do not have the amount of time in the day to work on muscle enough to counter what our body does metabolically. And that is just the truth of it. And so when it's better to be on a low dose medication and do as much as you can physically, or then rather than trying to fight all the time. Because like I said, you're pushing a boulder up a hill, and what GLP-1s can do is act like a tractor to help with that process. And once the boulder's up the hill, then you can adjust and do other things. Oh, my phone closed, and I need to get another question. If you have any questions, you can put them in the chat and I will answer them. I have so many questions I've gotten. Okay, so let's see, what's the next one? A lot of questions on GLP-1s. Hold on. What is an A1C? That's a good question. Okay. An A1C is a blood test that we use to determine partly what we determine someone's metabolic status, or where they are in the continuum, like I said, from pre-diabetes, insulin resistance, all the way up to diabetes. So what an A1C is it's a glycosylated hemoglobin. And what glycosylated hemoglobin means is blood sugar that has stuck to our red blood cells. When our blood sugar goes up, or wherever our blood sugar is, that blood sugar sticks to red blood cells, and they stay stuck to that red blood cells. It never comes off. Our red blood cells live in our body for about 3 months, and then it gets replenished by a new batch of red blood cells. So whatever your blood sugars have been doing during those 3 months can be checked by checking a hemoglobin A1C. So if your A1C is high, that means there's been a lot of sugar in the blood and it's attached itself to a lot of red blood cells. If your blood sugar is low, it will have a low A1C because it means there's been low blood sugar and very few red blood cells have very little glucose or blood sugar has attached to red blood cells. So that's why we test it to determine whether someone is diabetic or not, or where they are in the continuum. So if it's over 6.5, an A1C over 6.5 is diabetes. Any hemoglobin A1C from 5.6 to 6 up to 6.5, so 6.4 is pre-diabetes. And anything 6.5 or below is considered pre-diabetes, or just not anything. It's just considered normal. Now, you can be insulin resistant even with a normal BMI. And what that means is the insulin that our body creates to help us metabolize carbohydrates and our carbohydrate byproduct glucose is not working properly. So the brain acts like you're diabetic already. So all the complications of diabetes are there. All the issues that are caused by high blood sugars are there. And therefore, A1C is only part of the story. The other part of the story is free insulin. If free insulin is high, because what our brain does when it thinks something's not working, it tells the body to keep making more of whatever it is that helps the process. And so if blood sugar is not getting into the brain, or the brain thinks you're not eating, it will raise up insulin to help metabolize or manage that blood sugar. But it has nowhere to go. Insulin's like the key that goes into a lock and opens the cell so that the glucose goes in. Problem is, if there's not enough, if there's too many keys and not enough locks, then nothing opens. And so that's essentially what happens. And it just starts this vicious cycle. The other way you can tell if you have insulin resistance or prediabetes is your middle starts to grow. If your waist starts getting larger, then that is an indication that your body's laying down fat as a way of trying to protect you from the brain thinking you're starving. And so that's a clear indication that there's metabolic something going on. No matter what else is normal, all your blood tests can be normal. All of everything can be normal. But if your waist circumference, the measurement of your waist keeps growing, that's an indication that there's a metabolic dysregulation underlying, and that has to be addressed. And like I said, the best way to address it is with muscle, with, well, actually it's what I call the 5 M's. So muscle, meditation or mindfulness to get your cortisol down, protein forward meals so that your body stops getting the building block for fat, which is carbohydrates. Then the 4th M is meditation. Not meditation, medication if you need it. And then the 5th is, well, and that medication could be HRT, it can be GLP-1, it can be another medication that doesn't cause weight gain when one does. Like there's certain hypertensive meds that cause weight gain, there's certain antidepressant that cause weight gain, and you can switch to another that doesn't. And of course, I'm blanking on the 5th one, and I say this so often. I'll think about it when it comes back to me. I'll tell you. All right. Okay, there is a question in the chat. I was on Mounjaro 7.5. After a bowel obstruction surgery, I went down to the lower dose. Now I have a lot of sugar cravings. My A1C went up from 5.7 to 5.9. I will go up to 5. Yeah, usually when you're on 7.5 and then you come off, you have to start from the beginning. Anytime you're on a GLP-1 and you're off for more than 4 weeks, you go back to the original dose. The lowest dose is not designed to do anything other than to protect you from side effects at higher doses. But keep in mind, like I always say, weight loss is one of the side effects. Not all the side effects are bad. So, because weight gain is caused by metabolic disruption. And GLP-1 medications are metabolic correctors. And the side effect of that correction is weight loss. That's it. So I've been saying this a lot. I've been saying it over and over again, and you'll hear me say it over and over again, because it's just something that needs to be said. But let's see what I have here. So let's see. Someone says, I have polycystic ovary syndrome and endometriosis, along with type 2 diabetes and insulin resistance. So just so you know that type 2 diabetes is a type of insulin resistance. That's what causes it. So it's just, like I said, farther along the continuum. My A1C was 6.5. My insulin was 153. That's very high. High normal is 14 for insulin. I fought so hard getting on a Mounjaro because everyone acts like that's just the, fought so hard not to get on it because everyone said it was just the lazy way out. And you just need to eat right. Actually, this is one of the reasons why I hate them being called weight loss drugs. Because we end up getting all of the prejudice and bias around weight assigned to these medications. And when that happens, you know, a lot of misinformation follows. So basically, I'm not really sure what the question is here. But what happens when your body is trying to regulate blood sugar? It will overshoot with the one hormone that helps with that, and that is free insulin. And that's why we check for it if we're looking for reasons that might be causing metabolic disease. So I just say hello. Oh, thank you, Geneva. Thank you, Patsy. So, the other question I got was about hypertension and why is it so bad? That was the next question I saw on my thing. So, what hypertension is, and is pressure against our blood vessels. So our blood vessels are like this, and as blood flows through, it pushes against the sides. And that pushing against the sides is the pressure of it pushing against the side is what we call blood pressure. And we can measure that pressure through a blood pressure cuff. And when it is high, that means the pressure pushing against the walls of the blood vessels gets so high that they can burst. That is called an aneurysm. And depending on where that aneurysm happens, it can be fatal. If it's right near the heart, what's called an aortic aneurysm, depending on how severe it is, it can also cause death. If it's in the brain, it causes a bleeding stroke. If it's in other parts of the body, it just causes insufficiency. If it's if it's on your heart or on your kidneys or in your intestines, it basically reduces the amount of blood flow to that area. So when you think of high blood pressure, think of it like pressure washing. When you have something that's high pressure, and it's like a jet of high pressure pushing against something, what does it do? It strips away whatever's there. So if you've got a pressure washer, imagine high pressure hitting against something. High pressure can clean sidewalks, can get stains out of things. It strips whatever it hits. Well, when you have high blood pressure, it strips the inside of your blood vessels and it makes them weak. And weak blood vessels burst. So that's why keeping blood pressure down in the normal range is very, very important. And a high blood pressure is anything over 145 over 90. Now, we like to see it around 135 over 85 or below. Now, keep in mind, too low blood pressure can also be a problem. So that's another story for another day. But high blood pressure is over 140 over 90. And it can be an emergency, especially if you feel it. So that's why it's so important to know your numbers. So number you should know. Blood pressure, you should know your blood pressure. You should know your A1C. The number, not if it's good or bad or whatever. You should know the actual number. You should know your cholesterol, your total cholesterol, your LDL cholesterol, your HDL cholesterol, and also your lipoprotein A. Our lipoprotein A is another. There's also homocysteine is another number that we're kind of asking people to check for and to know, because that number can also be an issue. The other number you should know is your kidney function, which your GFR or eGFR. That number says how well your kidneys are functioning. And when I say know the number, know the actual number. Not whether it's good or bad, because that's subjective to someone else's interpretation. Know the number, write it down, keep a record of that. You should always know. And that includes keeping a record of all your medications and their doses and what you're taking it for. If you don't know, ask your doctor. Always know what your medications are for and how much of it you're taking. I know I'm going off on a tangent, but we're talking about health here, so you're going to get me on my soapboxes. So I see my insurance has put me on a mandatory app service to monitor my weight loss and keep my authorization for Zepbound. What's the best way to utilize the coach? The best way to utilize the coach is to ask them what their purpose is. And to get your questions answered. If you have any questions, you ask them. And if they cannot answer them, then you find someone who can. Essentially, what this monitoring is, um, I would like to believe that it is for the health benefit of those who are in their insurance system. My concern is that what it is to get people away from medication as quickly as possible. What I'm starting to see is that people are being taken off the medication because the number that was used to put them on the medication has been corrected. So if someone's BMI was over 30 and they were put on a medication and it went below 30, many of these programs will say, well, you no longer have obesity, so we'll take you off the medicine. The problem we run into, or if your A1C was 6.5 and you're diabetic, or 6.8, and now it's 5.5, you're no longer diabetic. That's not true. It just means you are corrected. It means you are treated. It means that you are in remission for that, but it does not mean it's gone away. As soon as you remove, so think of um, think of obesity, overweight, um, type 2 diabetes, all of it. Just think of it like a river, and it's kind of going along a river, and that river's raging, and it's raging, and it's just raging, and it's going, and it's really out of control. And then suddenly you put a dam in front of the river. You take a raging river and turn it into a nice calm lake. So if you come up to a nice calm lake and you say, oh, this is a nice calm lake, this isn't a raging river, let's take the dam away. And then you remove the dam. Guess what happens? That nice calm lake becomes a raging river again. That's exactly what these medications do. They take a raging river and turn it into a calm lake. Doesn't mean the river's not there. It just means it's been controlled. And once you remove that control, it goes right back. So that's unfortunate that a lot of these that's what's happening to a lot of people, and why I pretty much see anyone regardless of what their numbers look like, because I treat the person, not their numbers. That's how I was trained, and that's what I do. Let's see. Any other questions? We're getting to the half-hour mark, and I try to keep this short if I can. So let me look and see if I see any other. Let's see. I know I got some good ones in here. Hold on. So that's the problem. I should have put them all in one place. Because let me see. Okay, here we go. Because I often get a lot of questions on social media as well. Let's see. There was a question I had. Let me see. Oh, come on. I have the question. Where is it? I thought I had it. A lot of questions about GLP-1, which is understandable considering I've been prescribing them for 15 years. So I do get a lot of questions. Well, trying to see if I could find something that was not GLP-1 related. Okay. I just talked about menopause, which is another. Okay, it seems like I get a lot of questions. I've talked about the GLP-1s. I've talked about oh, so one of the things that I did talk a lot about is the biopsychosocial approach to chronic care. Um, so one of the things that's really important that when you're addressing anything as to why it is, what you need to do, how to correct it, how to maintain it once it's been corrected, is to think about the biology, the psychology, and the social impact of what it is. When so so let's just talk about, say, weight loss, because I'm talking about weight loss a lot and wellness. So when you're talking about weight, there's a biological component. We know this. We know it's metabolic. We know it's hormonal. We know this. We know that there's a genetic component. We know this when genetics hits triggers that causes weight gain, and it takes a certain level of behaviors plus the medication to reverse it. But it still takes something to stop the raging river, like I talked about just now, and make it calm. So once you're calm, you have a calm lake instead of a raging river. It's much easier to then start doing all the other things around that issue. But we must acknowledge and address any psychological issues that are there. That means psychological issues of fear of success, of weight loss. Then that's a real thing. Because in people who are afraid of losing weight because they're afraid of losing their identity, or they're afraid of upsetting people around them, their self-esteem starts to go up and the people around them don't like it. They suddenly become what is considered socially more attractive, and those in their circle don't like it, or you yourself may not like the attention. So there's the psychological part. And then there's the social part. How you get treated changes. And that can be either a good or bad thing for some people. It can be uncomfortable for some and welcomed by others. But all of those things have to be addressed because, one, psychosocial aspects of any chronic disease is where sabotage lies. It's where compliance lies. It's where we get people who need to do what they need to do in order to get better. And when we don't pay attention to the psychosocial, what happens is that there could be barriers to getting the medicine. And so if we don't pay attention to how much the medication costs, if the person can afford that medication, if the side effects are so bad that it affects their activities of daily living, what kind of work do they do? You know, if you give someone a medication and it makes them sleepy and there's someone who works with machinery, obviously that's a problem. If you someone has a job where you need fine motor skills, and you give them a medication that makes their hands shake, what do you think is going to happen? They're not going to take it. And so all of those things have to come into play and have to be addressed and looked at when addressing any chronic disease and treatment of that chronic disease. Oh, you said, Cindy mentioned the daily weigh-ins is unnerving. I have that fear that they will stop the meds. Thank you. Yeah, that daily weigh-ins, I mean, a lot of times those things that they have you do actually create a lot of disordered eating, a lot of disordered behaviors. They're behaviors we try to get people away from. Tracy says, all I can say is thank you. So wonderful to have someone who listens and understands how it all works. Finally feel heard and seen. Oh my gosh, thank you. Oh, you're gonna make me cry. Okay, well, I'm glad, because that is why I'm here. That is absolutely why I'm here. I was one of those people that was not seen and that was not heard, and I suffered for it. And as a result, almost died because I suffered. And I won't allow that to happen to anyone else, not on my watch. So one of the other questions I get, and I've asked this to be repeated many times, and you can go to my YouTube channel and find it. And this was it was how to make a good doctor, what makes a good doctor. And I talked about how patients can actually create a good doctor from the doctors they have. And one of the ways of doing that is by organizing your information in a way that helps doctors use it. We tend to use information in a way to see what patterns are out there. We're working with puzzles, and we're puzzle. When you come in, you're handing us puzzle pieces, and we're trying to put them together to give us a big picture of what's happening. So the more clear the pieces and the better the pieces fit together, the easier it is for us to see the picture and know what to do. If you start grabbing stuff from all over the place, we can't figure out where it fits. So, if you're talking about, say, an aunt or uncle, grandparent who has the exact same thing, that might mean something because it could be a genetic component. But if you start talking about what your friend who's not related to you uncle did in this situation, that's not helpful because they're not related to you in any way, and all it does is just tell us what information you know, but it doesn't mean that you can get the same thing. And so one of the things I talked about was the PPQRST. And the PPQRST is what you should write down for every single symptom that you have. Because this will make your appointments go faster, your doctors will love you, and they'll be able to get you what you need much, much faster if you organize your information in a way that helps. And so when you have a symptom, the first P is precipitous. What makes the symptom happen? Is it a pain? So if you're saying, I'll give you an example, pain. Every time I clench my fist, I get a pain. That's the precipitating. Palliative. What makes it stop? Every time I open my hand, the pain stops. Or if I take ibuprofen or Tylenol, then that pain stops. So precipitous, palliative. What makes it stop? Q, what's the quality of that pain? Is it throbbing? Is it stabbing? Is it a dull, even dull pain? Does it go from one to the other? It starts off as a dull pain, and if you don't do something about it, it gets worse and worse and worse. So that's the quality. R is radiation. Does it stay in the same spot? Do you only feel it in your joint? Do you feel it shooting down your hand or your arm? That's radiation. Or down your finger or into your palm. Does it stay in one spot or does it move? So that's the R. S is severity. How severe is it? So using pain as an example, is it so painful that it keeps me awake at night? Is it so painful that my hand pain so painful that I can't hold the steering wheel of my car? Is it not so bad? It doesn't stop me from doing anything. I can still cook, I can still bathe, I can still all of those things. Is it, so how severe is it? Is it severe enough to cause you problems and interfere with your activities of daily living, or is it not? And then T is timing. When does it happen? Does it happen in the morning? Does it happen in the evening? Does it happen right after you've done some activity? So, when? Does it happen on days that you go to work, or does it happen on days that you're at home? Does it happen, randomly and there's no pattern whatsoever? So that's the T. So PPQRST. If you do that for any of your symptoms, as many of those as you can for your symptoms, of course, not all of them are going to have radiating pain. It's not going to be painful. It's going to be some other symptom that can't be as well described. But if you can do most of that for your symptoms, your doctors will love you. Absolutely. So, I've already talked a lot about GLP-1 and weight management. As you can imagine, over the last month or so, as we're coming into the new year, I get a lot of questions about weight loss. I'm not going to keep reiterating. I have a lot of videos already on weight management. So if you want to go look at those, you can. Remember, subscribe to my YouTube channel, like the videos that you watch, comment on them as well if you want. I do look at all the comments and I do respond. Now, if you find that you aren't getting the questions answered that you like, or you're not really sure what to do next, you can write to me at help@drtumor.com. And I think I did it as a ticker along the bottom. Where is it? Banners. Let me see. Yep, here we go. Yay. So help@drtumor.com. So you can write to me there and I will respond. And I hope this was helpful. And I will see you next Tuesday. I am going to do something a little bit different this year. I'm going to start interviewing some other docs, bringing other docs in there so we can get some expertise from people who know a lot more than I do on a given topic. So if there's specific topics that you want to hear about, please write to me at help@drtoomer.com so I can find the doctor, the expert in that area, and have them come and talk to us. And then also you can get questions answered from that person as well. So good night. Thank you for coming. If you're listening later, hashtag replay, let me know where you're listening from, and I do appreciate your being here. So good night.